Good day. I firstly would like to thank Medtronic for allowing me to address you today at this meeting, and I'm going to discuss the advances in infertility treatment with hysteroscopic TrueClear tissue removal system. My name is Lawrence Gobetz, and I am one of the medical directors of the largest fertility clinic in Africa, known as Vitalab, and I must disclose that I am a Medtronic surgical proctor. This slide depicts it all. And if we think of this poor man in the dark in terms of a DNC and why in 2020 are we still performing this procedure, and why is there a code still for us as doctors to bill this procedure? As we know, in the best of hands, we don't curate more than 60% at the most, 70% of the cavity. So I say the DNC is dead. So long live the king, hysteroscopy, see and treat. And for those of you who can't get the word DNC out of your vocabulary, we now have a visual DNC. We have targeted tissue removal, and we can then analyze histopathologically the tissue that we have now completely removed. The next question we need to answer is the pathology relevant from a fertility point of view? And when should we be treating our patients with the various different pathologies? And our appetite for rigorous research has been blunted by the ease of abnormal tissue removal, even in the office setup, with Medtronic's TrueClear mechanical tissue removal system. Firstly, a unique system where we can mechanically remove the actual tissue we are treating, and it has a magnificent fluid administration system, which in its own right is a lecture on its own. Our lecture today obviously encompasses pathology that you see in your daily gynae practice. In excess of 30% of your patients present to you with abnormal bleeding, and various different pathologies that I'm going to address today that we manage with the TrueClear is also something that affects our infertility patients. So if we just look at polyps, the impact of polypectomy on infertile women. Firstly, there are 4 studies, 3 randomized, 1 prospective comparative, and all have only been looking at IUI and the outcomes post-polypectomy, showing a 2 times better outcome. Again, what we don't know is what percentage of the spontaneous conceiving population actually fall pregnant with polyps. There are 2 other comparative non-randomized assisted reproductive technology studies where removal of polyps less than 1.5 centimeters in maximum diameter did not seem to improve the embryo transfer results. Unfortunately, there are no molecular studies comparing the various different gene expressions before and after polypectomies within the endometrium, and therefore, as usual, we need more randomized controlled trials. So in our infertility patients, we are not going to leave a polyp. So if we notice this polyp either on ultrasound or HSG, we will remove the polyp. We will utilize the mechanical tissue removal system. We want to resect right down to the base of the polyp, as we'll show you on this video. And it sometimes is more challenging when the polyp is sessile, or if it's fundal or by the corneal region. But we have a 0-degree scope, and we're able to minimize any kind of direct injury to the nearby endometrium, and the procedure is very simple, probably less than a minute, and with very little fluid used in this process. Let's take a quick look at leiomyomas, the enigma of our fertility work. And we know these fibroids are derived from single tumors initiating myometrial stem cells. There are 3 different cell populations within these leiomyomas. There's well-differentiated, intermediate differentiated tissue, and there are fibroid stem cells. Now, the tumor growth is more rapid when higher proportions of fibroid stem cells are present. Leiomyoma stem cells express low levels of estrogen and progesterone receptors, suggesting that there are other mechanisms, for instance, a paracrine mechanism that seems to be controlling their growth. I grew up on this paper because this was when I was an intern at Baragwanath Hospital, one of the largest hospitals in the Southern Hemisphere. And this article was by Buttram and Reiter. And they showed how fibroids impact on the hemodynamics within the actual myometrium. And as you can see, the fibroids will compress initially the low pressure out system, not necessarily occluding the high pressure inward system, creating the venous lakes and therefore the increased menstrual blood loss that these patients have. And these fibroids must definitely impact negatively on ultimate outcome. And what do we have in the literature supporting this? And if we look at an arteriovenogram of the fibroid vasculature, you can see this really looks like quite a picnic in there. And if this in any way does not disturb the function of the myometrium and ultimate implantation and outcome from a live birth point of view, it's very difficult to understand that. So besides the vascular disturbance, we know that there are chemical signals that affect implantation. And looking at figure 1, figure 2 fibroids, we know that in the endometrium overlying the fibroid, we have a deficiency of HOXA10 mRNA, and not only just where the fibroid is, but scattered throughout the whole endometrial surface. So one little area where there is a fibroid impacting on the junctional zone or on the endometrium itself affects the whole endometrium, whereas if the fibroid is away from the junctional zone or the endometrium, we find the HOXA10 mRNA levels within normal values. So paracrine effects, where there may be other cells which are signaling cells affecting the target cells, are something that need a lot more work on to try and understand this as to how these fibroids affect the outcome from a pregnancy point of view. Looking at the fibroid literature, there are numerous articles looking at the effects of the position of fibroids on fertility. And we know that submucous leiomyoma impact adversely. It affects implantation, there's abnormal increased uterine contractility, there's a disturbance in the endometrial cytokine expression, there's abnormal vascularization, there's chronic endometrial inflammation, and as I mentioned, reduced HOXA10 mRNA levels over the fibroid and the rest of the endometrium, causing defective decidulation with reduced implantation. If we move a little deeper with the fibroid and looking at the figure type 3 intramural fibroid on in vitro fertilization or intracytoplasmic sperm injection outcomes, we have a retrospective cohort study showing that the figure 3 exerts a negative impact on the rates of implantation, clinical pregnancies, and live births in patients undergoing IVF-ICSI, but does not significantly increase the miscarriage rate. The deleterious impact of figure 3 fibroids was remarkable in women when the diameter of the fibroid was greater than 2 centimeters. So looking at the old way that I would remove a fibroid, this is a figure 0, and the old scissors and grasper technique, where, and I still believe you need to know how to use a scissors and a grasper prior to then moving on to the hysteroscopic TrueClear instrument, because it can't always solve all your problems. And the problem here is this fibroid is now rotating with the fluid, and it's extremely difficult to grasp it and get it through your 7 or 8 millimeter dilated endocervical canal. So now we move on to, well, let's use electricity with the resectoscope. What happens? We have chips, we have bubbles, we have not a good understanding of how deep the necrosis effect is from the thermal effect. And we have to keep retracting the scope because we've constantly got bits and pieces of the fibroid, chips as we call them, that we now need to keep taking the scope out, getting the chips out, putting the resectoscope back in. And I refer to this as the war zone. They're the bubbles. You can actually see some arcing. And again, how does one understand the depth of thermal necrosis? And you can understand, and I always say, bottom right, don't burn the turkey. If you're working in a uterus that you are wanting to achieve a pregnancy in afterwards, stay away from bipolar or monopolar cautery within the uterine cavity. So let's move on to the ballet. From the war zone to the ballet. Here is a Figo 0 being removed with the TrueClear hard tissue removal system, and just watch how easy and how neat and how clean, and you do not have to keep retracting the scope to get any chips out. And as you resect the tissue is aspirated through the same device, and it then gets captured within a little bag within your within your fluid administration system, and that is then cut off, put into a formal saline bottle, and submitted for pathological or histological assessment. I would now like to take you through my technique of removing a Figo 3 fibroid. And what's important is to use your pressure and reduce your pressure to watch the bulge. And there you'll see the bulge. And I open up the endometrium, and I think it's very important not to take your TrueClear and apply it straight to the endometrium and gobble all your way down to the fibroid. So I use my scissors again. I open the endometrium because I want it to heal as a bandage, and I then loosen the capsule off the fibroid. And once I've done that successfully, I am then able to place my TrueClear hard tissue, or as we knew, the Ultra, and able to completely resect this fibroid down to the capsule. And the result is, again, phenomenal. And the procedure here took no more than 3 minutes to completely resect the fibroid. Unfortunately, with Ds and Cs for retained products of conception, there is a reasonably high probability that we will have retained products, and one will have to remove them. And if we have to do another D&C, there's a high risk of developing Asherman's syndrome. So we are faced quite often with these patients, and the TrueClear is a phenomenal, especially the soft tissue mechanical tissue removal system here is phenomenal to be able to completely resect the retained products of conception. Now, with your missed abortion, I always take a biopsy of the chorionic villi, and here you will see I do an embryoscopy, look at the fetus, and here we're able to, with a grasper, we're in the amniotic sac, we're able to grasp the chorionic villi, which we then submit for NGS, next-gen sequencing. Knowing whether the pregnancy was euploid or aneuploid helps us to manage the patient subsequently, because a lot of our patients, we cannot afford not even one miscarriage, because a lot of them are reproductively older women, and this helps us and guides us as to what we would specifically do next time round, so we don't end up with the same result. Now, I use the mechanical tissue removal system, and I know it's off-label, although it's no different to doing a hysteroscopic polypectomy. And here we are showing you a missed abortion. This is a 7-week pregnancy. You can see the cavity. The cavity is pretty much okay to work in, and I use my soft tissue mechanical tissue removal system to get the sac and the placental area, the decidulized area, out, and I leave the rest of the decidulized endometrium, which you will see now, to come away within the bleeding afterwards. And you can see this decidulized endometrium here. And this is the tissue that we keep scraping out, and that's why D&C takes us that long, because the sac is out, and now we spend at least another 15-20 minutes evacuating this tissue. And I think that is one of the reasons why we get Asherman's when we do Ds and Cs with a pregnant uterus. I would like to take you now through another off-label use, and that is I use it to remove redundant tissue within the uterus when I am correcting a T-shaped uterus, and also sometimes with very large septums, which I resect with the scissors. I may be left with quite a bit of redundant tissue in the fundus of the uterus, and I then use the TrueClear Ultra or the hard tissue removal system to then clear up that for me. And this is the pre-op HSG showing you the T-shaped uterus with a bit of depression in the fundus. So initially I open the fundus, and importantly I undermine both anterior and posterior to keep the walls apart. And once I have then got the fundus corrected, I will then move to the shoulders, and you'll be able to see there I am resecting posteriorly. And now you can see these shoulders, and one has to incise these shoulders with the scissors, and ultimately you end up with a large amount of redundant tissue. and take your time, resect right up to the internal ostium or the tubal ostium. There you can see this thick extra fibrous tissue that we have, and I then use the Medtronic to completely clean this up for me, and I then give the patient post-operative estrogen for a minimum of 2 weeks. I usually use 3 weeks, and in the last week I give them sequential progestogens to then allow them to have a normal period, with they then follow up HSG to assess the outcome of my surgery. And here you can see the TrueClear Ultra that we use to finally remove the redundant tissue. And that's a picture basically once we are finished. You can see the enlargement of the cavity, and we've probably got a 1.5 to 2 times increase in the size of the cavity. And we have had, here's the post-op HSG showing you the absolute normal cavity, and we have a reasonable size study of our own now showing how the outcome of this procedure in patients who've had previous implantation failure or early miscarriages. When we correct the uterus, we get a take-home baby. So just to end off, if we talk about hysteroscopic mechanical tissue removal within the infertility group, and I think this pertains as well to using it for pathology in your general day-to-day gynae practice, we operate in saline, and that decreases the risk of fluid overload and hypernatremia. We have no thermal injuries to the endometrium nor the myometrium. This continuously removes the tissue pieces while you are working in the uterus. We have a clear visual field. We decrease the risk of multiple instrument placement, and therefore reduces the risk of uterine perforation, creating false passages, and the constant in and out of the scope does increase the risk of air embolism in the patient. It facilitates the removal of type 0, 1, and 2 submucosal fibroids. It decreases the op time, and also the fluid deficit is a lot less, and we can use smaller diameter scopes in the office setting. And finally, if we look at this picture on the left, you can see every pathology on this picture we can manage with the Medtronic mechanical tissue removal system. I must have moved the picture because my FIGO classification here has moved off to the left. But retain products of conception, your FIGO fibroids, don't go more than 2. I do go to 3, depending on the level of competence. I also use ultrasound, which is vitally important when you're doing hysteroscopic work. Have an ultrasound to complement what you're doing to be able to assess that you've completely removed the pathology. So, more options mean more control in every procedure. The TrueClear system is a complete technology platform for hysteroscopic procedures. It brings together high-performance scopes like the TrueClear Elite hysteroscopes and incisionless tissue removal and advanced fluid management. Together, they deliver access and clarity so you can do what you do best, and that is to treat your patients. And right down here at the bottom, I have my emoticon of me feeling sad. Why am I sad? Because currently no more than 30% of gynecologists perform operative hysteroscopy, and the time has come for more mentoring, more proctoring, and for us to get more gynecologists to do more operative hysteroscopic surgery, because that is by right our stethoscope. GQJ. Dankie is the same in Afrikaans. Thank you.